Okay, so I'm going to do a presentation on elderly care, and this is to sort of set the scene about what we're doing in the care home. It's for new care assistants to really understand the complexities of caring for older people. Um, so we're going to go over like the general situation with the people that we're going to look after in the care home. I'm going to go over some common diseases and problems that are associated with aging and their role in either helping to prevent them or in assisting the resident to live with the conditions as best they can. So the older person. So people in the care home, in a nursing home or a care home nursing status, they're going to be anywhere from, on average, from like late 70s up into the 80s and 90s on average. Um, so people in the developed world are living a lot longer. So they're living up to, on average, about 80 years old. However, most people are living up to that age, but in a very unhealthy manner. Now, you could say they've almost got last third or quarter of their life is what would be called morbid. So they're suffering from a lot of conditions that are related to lifestyle, and it is actually like the developments in medical science and technology that's allowing them to live to great ages, but in very quite poor health, and that is what we see in the nursing home. I mean, if someone led a healthy lifestyle with, they're doing a lot of physical activity throughout their life consistently. They have a good diet, especially very minimal amounts of refined sugars in their diet. If they're living in a more rural setting, away from polluted air, and they're not smoking, limited alcohol intake. If they can sustain that for the majority of their life, then they're still going to get up to those advanced ages, but they're going to be in better health. However, that's not the situation. You've got people living now who are overweight or obese. I think pretty much the majority of the population now. Very low levels of physical activity, very high consumption of refined sugars, and this is not how humans would naturally live, like when we were hunter gatherers. So in fact, not doing physical activity, eating refined sugars, leading to obesity, etc. This is making people suffer from what we call morbidity, so suffering from like disabilities, and they develop things such as type 2 diabetes, cardiovascular disease, high blood pressure, even like Alzheimer's disease is associated with poor lifestyle. So this is what we're seeing in the nursing home. So we're seeing people who have got to a very advanced age, but they're in a very poor state of health, and it's medical science and technology that's got them there and keeping them there. And as such, it's very complicated to look after these people, which I'm going to go over. I'm going to go over in more depth now. So there's many diseases associated with age, advanced age. So dementia. I'll go into this in more detail, but the most common one would be Alzheimer's disease. So that the incidence goes up with age. Depression. So depression being the most common medical condition amongst all age groups, and it does increase with age. Arthritis. So specifically, we're thinking of osteoarthritis. So that increases with age. And just to speak a bit more about this now, I mean, um, people may think like erroneously that osteoarthritis is associated with things like running. Let's say like osteoarthritis of the knee. However, osteoarthritis is associated with older age, being female, obesity, and um, and uh, it's associated with injury to the joint. So if you think about like if someone is excessively overweight, it's not that they're standing up or doing a lot of walking or running with that extra weight from the body fat, and that's putting stress onto, let's say, the knee joint, and over time leading to osteoarthritis. It's the fact that the excess body weight is causing chronic inflammation, which leads to the osteoarthritis. Okay, so osteoarthritis is associated with decreased activity. So if someone does more activities, they're less likely to get osteoarthritis. But this is something that we would see quite a bit in the nursing home. Stroke. So the incidence of stroke will increase as with age. Coronary heart disease, Parkinson's disease, type 2 diabetes, a very significant condition. And there's also plenty of problems is associated with elderly care. So pressure sores, which I've done a separate presentation on. Skin flaps. I mean, their skin is weaker. That is why you get pressure sores and skin flaps developing. Falls, malnutrition increases with the risk increases with age. And associated with that, you have increased or decreased body mass index. Rarely will you see, or not that often, you'll see a resident who's got a body mass index that is within the healthy range. It's either at one or the other extremes, or moving that way. Contractures. I will talk more about contractures in another presentation. Their increased risk of infections like chest infections, urinary tract infections, and they're more likely to die because of those infections. If you look at like the COVID-19 pandemic, it is mostly people over the age of 50, 60 who are making up the people who are dying of COVID-19. They have increased risks from the environment, so from the climate. So in winter, you're going to see excess deaths. Partly that's due to increased infections in the winter months, but also older people living in their own home are more vulnerable to suffering from hypothermia. They're also, older people are more susceptible to food poisoning. They're more likely to have a sensory impairment, at higher risk of constipation, decreased mobility, loss of bone density. So a person will lose their bone density as they get older, more so females. And the significance of this is that they can fracture a lot more easily. They can suffer from incontinence. So incontinence is the loss of ability to decide when you pass stool or urine, and continence being the opposite to that. They're very vulnerable to abuse due to lack of mental capacity or sensory awareness. They're vulnerable due to lack of mobility, isolation, etc. And very typically when people get older, they're more isolated and can suffer from loneliness. And because a lot of these conditions they have medications prescribed, but you can get the cumulative effect of side effects of the medications, and you may get one side effect from a medication that you have to then prescribe another medicine to try and solve the problems. So, for example, like a pain relief medication such as codeine is likely to cause constipation. So then we have to ask the doctor to prescribe a laxative to manage that. Renal function decreases with aging, so that also can affect which medicines they can have, and it can affect that. It can be the result that we have to monitor their blood tests more often, etc., etc. So it's a lot more complicated looking after older people than a younger patient. So the increased infections. So past the age of about 30, our immune systems are slowly declining. We're more likely to suffer more serious infections. We will have an accumulation of like immunity to past infections, but as we get to the very advanced stages, our immune system is a lot less effective, and so you can see like such diseases as the COVID-19, how it can be more serious in older people. Coming into the winter time, we'll see more viral infections. There will be a risk of influenza, pneumonia. The COVID-19 is going to increase, and also just a common cold. So what people don't understand is the common cold may be just a mild illness for younger, healthy people, but if an older person suffers from a common cold, and that could actually lead to their death, either due to development of a viral pneumonia or secondary bacterial pneumonia, and it could actually lead to their death. So to reduce the risk and incidence of these infections, so staff need to follow the infection control guidelines, implement techniques such as universal precaution and barrier nursing when necessary, which I cover in separate training. But it's very important that we protect the residents from infections. The climate or environmental illnesses, so something such as hypothermia just should not be happening in the care home. So if you notice a resident's room is too cold, then we need to put a portable heater in there. We need to tell the management and the maintenance staff about the issue. If we can't get a portable heater in there, we may need to move them to another room that is adequately heated. We need to have enough blankets or duvets on the resident. Consider, closing the window if it's that cold. Just basic things, but this should be never happening that a resident is developing hypothermia. The other risk is during the summer months, especially at the beginning, or if it's been a cold summer, then suddenly it gets hot. There's a very big risk that residents could develop what we call heat exhaustion. It's very unlikely they develop heat stroke. So heat exhaustion is pretty much it's where someone's in a hot environment and they basically become dehydrated. Now, heat stroke is where their bodies become so hot that it doesn't function correctly anymore because it's become too hot for the enzymes to work properly. So that's a lot less likely to happen. That's more likely to happen in someone doing like extreme exercise in a hot climate. So the resident is more at risk if it suddenly gets hot from heat exhaustion. So again, if in summer months we have to have the windows open, fans in the rooms, we do have air conditioning units that we can put in the hottest rooms. We can only have the doors open on a fire magnet because they're all fire doors. If a room is particularly hot, we could again move them. You want to close the curtains so the sun doesn't get in there. They just have a sheet on them. And then very importantly, they need to drink more water or any fluids. So this is a significant problem. So it can take at least 3 weeks for a young healthy person to acclimatise to hot conditions. So in a very old person, that response is going to be diminished. The other problem is, as we get older, the part of our brain that senses our body temperature, the hypothalamus, becomes less effective. And this will happen in everybody, not just people like with a dementia. So you're going to see residents who will want to come down in very thick jumpers and jackets, even on like very hot days when the staff are just wearing like short sleeve uniforms. And that's what's going on, because they can't sense the temperature in the environment properly. Okay. Contractures. This is to some degree preventable. So if a person's staying in the bed long term, they're not moving their joints, they're not standing up, walking, etc. They don't have the effect of gravity, like even if they're sitting up. What can happen is that the joints can become stiff and like lock in one place, as you can see from this picture. And the joint can become painful. You won't be able to move it, so there can be problems with moving and positioning. So this person may not safely sit on a seat if you hoisted them out of the bed. There could be a problem with pressure sores developing. So where this leg is touching this leg, there could be a pressure sore develop between there potentially. There's also the risk of like a fungal infection in the skin crease. Is generally very difficult to manage and position them correctly. Now, to some degree, we can prevent them. So before they happen, people who are bedbound, they should either have active or passive exercises every day whilst in bed. This diagram that just demonstrates it. So it's just like a normal range of movements of the limbs. There's also medication that they could take that stops the seizuring and the stiffness in the muscle. There's also we could refer to the physiotherapist and occupational therapists, get special like foam cushions to try and extend the limb out. But once it's got to this stage, I mean, they may be able to get a physiotherapy referral and maybe able to do some sort of exercises to release it to some degree. But it's the only option would be a surgical intervention, and that's not going to be feasible in our service users due to their advanced age and comorbidities, making it such a risky proposition, and the possible suffering it's going to cause them if they have surgery. Malnutrition. So this is a risk in older people. If they're not taking in enough food, then there's a risk that they're gonna suffer malnutrition. There's not a like an agreed upon definition of what malnutrition is. Basically just means poor nutrition. We may see vitamin deficiencies, mineral deficiency conditions. We can see damage to the immune system if people are not taking the appropriate nutrition. So the services will have a care plan detailing how to try and prevent this happening. We use the body mass index. That's the BMI there on the slide. If it's below 18.5, then that means that they're at very high risk of malnutrition. If the BMI is 25 or over, then that means they're overweight, and if it's 30 and above, that means they're obese. We will try to feed them according to the Eat Well plate, which is divided up. The food groups divided up into this fashion. So a third of it should be fruit and vegetables, a third of it is rice and potatoes, and the rest is dairy products in this proportion, sort of meat, fish, eggs, etc. This proportion, and this like the high fat or sugary food that should effectively not even be on the plate. In the latest version, I think they've taken it out. So that is just something that should be had occasionally. Constipation. So if someone is not moving very much, they're bed bound, they're at risk of developing constipation. That's because our digestive system to some degree relies on our body movements to help the digested food along the tract. Also, if the resident's not drinking enough due to their dementia or worries about incontinence, then they could also become constipated, as you need lots of water in your body to have a soft stool that you can pass easily. Also, if they're not eating enough fiber due to their general decline in consumption, that also will contribute. Other medications they're taking can lead to them developing constipation. So the treatment and the prevention are pretty much the same. So yes, someone moves about more, which may not be feasible in a service user. They drink more water, they eat more fiber, and then also the GP may prescribe laxatives to be taken both as a prevention and a treatment of constipation. It can be very serious constipation. It can cause abdominal pain. It can cause complications in the bowel. Even some situations it could lead to the death of someone if it obstructs the bowel, for example. Dementia. So this is a very significant problem in the developed world. It's increasing. The incidence is increasing. There's over 100 different diseases that are leading to dementia. They have dementia is like a syndrome. It's a group of related symptoms that make up this syndrome, which is caused by over 100 diseases. So someone has dementia, they'll have memory loss, sort of slower thinking speed, their mental agility or flexibility is lower. There may be differences in their language or understanding of language, and their judgment can be impaired. Now, different causes of dementia may present slightly differently. So, for example, like Lewy bodies dementia or Parkinson's disease associated dementia as well, though they're not the same. They're two separate types. They're very similar, but they are separate. They will both have the characteristic of visual hallucinations, which you wouldn't typically see in, let's say, like Alzheimer's disease. You also get vascular dementia. You can get alcohol-related dementias such as Korsakoff syndrome or Wernicke-Korsakoff syndrome. It is related with age. You can see dementias in younger people, like Creutzfeldt-Jakob disease, which is associated with what would be termed mad cow disease. That's due to consumption of a prion, which causes damage to the brain. So there's lots of different types of dementias, slightly different presentation, but they do have these common symptoms in common. Alzheimer's will be the main dementia we're seeing in a nursing home, followed, I believe, by vascular dementia, and then I think a mixed dementia, and then I think frontotemporal lobe dementia. So Alzheimer's disease, it is associated with aging, but also it is associated with lifestyle. So it is associated with a lack of physical activity. It is associated with diet. So that's one reason you're seeing it increase in the developed world, people's poor lifestyles. You still see it. You see it somewhat in developing countries, but nowhere near what you'd see in developed countries, and it's not just a function of age. It is something to do with lifestyle as well. You'll have separate training on dementia. I think that just the best simple advice here is you just treat them like a normal person, like how you speak to anybody. You're respectful to them, you listen to them, you just treat them like a normal person. Diabetes. The two main types of diabetes is type 1 diabetes, type 2 diabetes. So we're mostly going to see type 2 diabetes in the nursing home. And type 2 diabetes is its incidence does increase with age, but that's more because it's an accumulation effect. So it is basically a lifestyle disease. It's due to inactivity, it's due to obesity, high consumption of refined sugars over time. There's a genetic component. Some people are more at risk. Certain ethnicities are more at risk. So South Asians, for example, are a lot higher risk than Caucasians. Like Caucasians, the risk would start in when you start to think you start seeing it in people, it would be in their 40s. But in South Asians, it can be from 25 years old. It is predominantly a lifestyle disease. In the small remaining numbers of hunter-gatherers that are investigated worldwide, studied, there's just no history of type 2 diabetes. So if you think that they're very physically active, they're walking or running between 35 to 70 miles a week, plus doing like some manual work and like ceremonial dancing, etc. So they're very physically active. They basically do not eat refined sugar products. Probably the only thing they could eat would be like honey, and they're not going to get massive amounts of that. They're also not going to consume that larger amounts to be able to become overweight or obese, so that their BMIs would be within the healthy range, and you just do not see the type 2 diabetes at all. So this is really a disease of industrialization. It's just the lack of physical activity and the high consumption of calories and refined sugar. Some people are going to be more susceptible due to their genetics. What can you do to prevent it? So what you do to prevent it is a high volume of physical activity throughout your life, very small consumption of refined sugar, and maintaining your body mass in the healthy range, so not being overweight or obese, so reducing your actual consumption of calories. So if someone does develop type 2 diabetes, the treatment would be, as I just said, to prevent it. Some people have been able to reverse it or put it into remission, and typically they've lost a lot of weight to achieve that. So they've maybe lost 15-20 kilograms in body weight, plus not stopped eating refined sugar products and done a lot of exercise. And if they can sustain that, and this is the problem, if they can sustain it, that basically that type 2 diabetes is in permanent remission, so it is effectively cured. However, that's very few people who can become motivated to do that. That's not going to be possible in a service user. So we pretty much have to just monitor them. We will give them the diet that I discussed earlier, the Eat Well plate. They could occasionally have refined sugars, but we'd have to be very careful about them having that. They may need medications, oral medications such as metformin to try and manage their blood glucose levels, because that's the problem. If someone has type 2 diabetes, it's a problem with the the regulation of their blood glucose levels. So you have high blood glucose levels, it damages everything in your body. It damages all your blood vessels. It's the leading cause of blindness in the Western world, the leading cause of kidney failure, the leading cause of having to have limbs amputated. They're more likely to have infections or die of infections. The leading cause of death would be myocardial infarctions, so heart attacks. So it causes premature death, but it also causes morbidity. So that those disabled last sort of 30 to 30 years of their life. So it's definitely something that can be prevented, but it's the modern living that's leading to it. Symptoms, if you've got this high blood glucose, then you're going to be very thirsty, you're going to urinate more, you're going to feel tired all the time. This is more in type 1 diabetes. You might get weight loss and loss of muscle bulk, not in type 2 diabetes. You may get like thrush infections, so these fungal infections in the vagina, cuts and wounds that take a long time to heal, and then change in your vision. So this will be very slow over time, type 2 diabetes. So you may go to your doctor because you're urinating more, you're feeling tired, and then they just do a blood test, and that's the diagnosis of type 2 diabetes. So pretty much type 2 diabetes is where your hormone insulin is your body cells have become less sensitive to it. So your muscle cells and your fat cells, which it acts upon, have become less sensitive to its effects, and so don't let that glucose in after you eat a meal. So you have permanently high blood glucose levels. We'll do more about this in other training, but this is just like an introduction. Stroke. So stroke, good way to describe it is a brain attack. So you have like a heart attack, that's like layman terms, but a stroke is a brain attack where there's been interruption to the blood supply in a part of the brain, either due to a clot, a blood clot, which would be termed an ischemic stroke, or you can have a hemorrhagic stroke where you've had one of the blood vessels is suddenly burst and bleeding, but they both result in the same outcome, which is a reduction of blood supply to a part of the brain. And typically it depends on part of the brain, but typically you'll see sudden paralysis down one side of the body, so drooping face, an arm or a leg that they can't move or can't move very well. If it did happen in a nursing home, we do the FAST assessment. We'll talk about that in first aid training, but here we're really more focused on the disabling effects of the stroke. So it can be I believe it's a leading cause of disability. Many residents come into the nursing home due to stroke. Previous to their stroke, they've been in good health, able-bodied, and then they suffered a stroke, and that's the reason they have to come to the nursing home. The main thing to consider is there'll be moving and positioning considerations, as if they're paralyzed on one side of their body. There could be speech and comprehension problems if it's affected parts of the brain that then controls speech. There could be changes in their visual field, so you may have to position yourself so they can see you appropriately. They may have pains in their limbs, so you may have to position their limbs appropriately on pillows, like upright, so it reduces swelling and pain developing, and then thinking about medication. Their swallowing can be weakened, so they may need thickened fluids or a puree diet. It may lead it could contribute to dementia, like the vascular dementia. So it's a few things to consider. And the last thing to talk about would be Parkinson's disease. So Parkinson's disease, its incidence increases as we get older. It's not lifestyle associated, so it's nothing that you can do to prevent it. So if you do more exercise, if you eat less sugar, etc., if you don't smoke, that's not going to affect whether you're going to develop Parkinson's disease. It's a progressive condition. It affects the part of your brain that deals with movement. And typically the symptoms could be tremor, so involuntary shaking in particular parts of the body, slow movement, and then some periods where you might be stiff and inflexible muscles. Now this may start very subtly, and over the years it will just get worse and worse and worse. And as it gets into later stages, there could be swallowing problems. There's a dementia that's associated with it. The movement problems will be more severe. You may need to have like a use of a sling hoist to mobilize, etc. So similar sort of problems to the stroke. It's really just managed with medications, but they typically get less effective over time. It's very important they have their medications at the right time, and they need to be very closely managed with the Parkinson's disease specialist nurse, and it just really needs to be managed with good nursing care. So that's a few conditions that I've just covered, and it's just something to start you off.